like to at least put some of that on our website. I'm not sure where else we'll show it, but anyway, unless there's some reason you don't want us to do it, let us know. Okay. So I think we're going to go ahead and get started. You're all set to go.
Okay.
You're mic'd up?
Where's the thing?
Okay, we'll mic you up. I'll introduce you. Then I think what we'll do when you're done, David, you just have a seat here.
Okay.
And then Doug Smith, you're going to go second. And then you can have a seat here. And then Doug Hasbrook's going to do the wrap. He's going to do his own presentation and then kind of give an overview. And then because there's just a few of us here, we'll just sort of have an open Q&A session. And when we're done, we'll all go. Okay, so.
Looks like I'm allowed to do this too.
You're allowed to be very comfortable. And you got your clicker. So Dr. David Harris comes to us by way of Idaho Falls. He holds a University of Utah undergraduate degree and a medical degree. Completed his residency in pediatrics at the Children's Hospital National Medical Center and a fellowship in pediatric endocrinology at UCSF. He's board certified in general pediatrics and practiced as a pediatrician at both Westside Pediatrics Clinic and Granger Medical Clinic in West Valley City between 82 and 2012. Granger Medical Clinic is one of our leading clinics, by the way. He was named medical director for Altius Health Plans in August 2012 and considers himself the new kid on the block in the insurance industry with a pediatric primary care perspective. Thank you.
Thank you. The one on the top here?
The one on the top is the laser.
Whoops. So forward. Got it. Our former parent company was Coventry. These slides are prepared by under their aegis by Dr. Dennis Harston, who's the Chief Medical Officer at Altius. We were officially acquired last week by Aetna. I have permission from my CEO to continue to use the Coventry name. Aetna's basically left us alone for a while. I guess we're pretty safe for a few years, so they just say, talk amongst yourselves, we're verklempt. This presentation was given to a group in Kansas City called Integris, which is a integrated hospital physician organization. And there's one use of the term that I didn't catch to take out. So when you see Integris, just fill in generic physician or organization, or at least healthcare organization. These are the four components of Coventry's medical management program. There's a wellness program, a disease and condition management program, a complex case management program, and utilization management and concurrent review. I'll go through those briefly. I imagine all this stuff's in your booklet, so I won't bore you with reading something that you can read yourselves. But basically, this program is describes the wellness program. Interestingly, it's available to all employees and even employees that don't participate in the benefits program. It's designed to supplement other medical management programs and is helpful information for individuals who want to take better charge of their health. There's lots of online resources for self-care involving those divisions. Interestingly, at least for me, there's a lot of kids and teen health stuff available. A lot of it's related to obesity prevention and management. Pardon me? That's part of it. I can't remember what all is in that, but I could figure it out for you. The Wellbeing portal has access and links to these various subjects. And it's quite user-friendly. It's pretty. It's got zinnias. In terms of conditions of interest in our disease management program, these are the diseases that are actively managed around the country. Obviously, we don't have a lot of HIV or not an awful lot of hemophilia around here, but we've got everything else. In terms of Compass Care, this is our care management program wherein patients with complex diseases and a large claim history are managed at various levels of intensity. They're managed now with what's called a care management tool, which was recently rolled out, which nurses can apply to each patient on a monthly basis and monitor their migration from the one end of the spectrum of being very poorly informed and not very proactive about their health condition up to somebody who can be discharged from care management. So we presently have about 60 patients in care management actively at Altius. In terms of healthy outcomes, that's the name of that manages our, or at least is attached to our program of utilization management and concurrent review. So in terms of concurrent review, all hospitalized patients are reviewed to one degree or another. On the low end is, in report is, for example, OB, pre-authorized knee surgery, and then they go to the patients that are sick, and we help keep track of their progress through the hospital. And if things seem to be getting slowed either by diagnostic difficulties or what appears to be delay in care, we start to get a little bit involved, but it's pretty rare that we have to do that. Interestingly, from my own standpoint, there's still quite a bit of management applied to Primary Children's Hospital, which is somewhat directed from above, but felt by me to be largely unnecessary because they're always in such a bed crunch. They're getting people out quicker than most practicing pediatricians want them to. But we still manage them mainly because Coventry wants us to. There's apparently quite a bit of oversupply of neonatology in some markets. We've got the opposite problem here. In terms of national practice standards, I spend probably 75 to 80% of my time accessing tech assessments that Coventry writes, and now I guess I'll be switching to Aetna. Interqual is a system of criteria that are developed by a company that has their hands in a lot of different areas called McKesson. And those are similar to Milliman and Roberts guidelines. And so we, for pre-authorization for procedures and for continuous review of hospitalized patients, we have patients fit criteria for Interqual. If they don't fit, they have to come to a medical director for judgment about whether this is someone that we should allow to not fit criteria, which is probably reasonably 10 to 15% of the population. And we're then allowed to authorize care based on our judgment. Third-party review refers to basically on an appeals basis. If someone disagrees with care, we can send out cases for outside appeal. We contract with several IROs or independent review organizations. And that's commonly quite helpful in areas that either Dr. Harston, who's a family practitioner, or I, or other individuals within Coventry don't know enough to really render opinions. High Performance Network is a Coventry term for accountable care organizations. This is the example of Integris that I forgot to get rid of, but replace that with medical care organization. So basically, the relationship is contractually defined in terms of how premium dollars are divided. There's a transplant network for transplants that independently manages those nationwide. In terms of performance-based incentives, we try to get hospitals and PCPs and us thinking on the same wavelength in terms of care management, and that has to do with quality improvement measures and incentives to providers. Because as you've learned, commonly hospitals and PCPs have opposite incentives. In terms of enhanced data sharing, there's been some systems purchased by Coventry over the last couple of years to measure provider performance and identify gaps in care, and of course marketing opportunities. I imagine you've seen all this printed up in various ways, but basically the new model is a PCP-centric care model where providers practice to the maximum ability of their license, which allows more continuously excellent care rather than dumping everything on a PCP to manage minor stuff for which they'd never have enough time. These care teams are being encouraged around the country. Enhanced member access has to do with the fact that there's enough people there to take care of them, which has to do with practicing to the maximum of your licensure. There's, of course, collaboration between the various entities involved in the contracts related to disease and care management program. And then these technical tools in terms of applying evidence-based medicine compliance and gaps in care, and then they can do some predictive modeling in terms of when there's gaps in care as to what the likelihood of costs incurred is going to be. You can see the goals. Basically, we need to improve care quality and decrease costs. This is a little bit more definition about the tools. The care management tool is that which is applied by the care management nurses to manage patients at home, and the provider support tool is one which is being rolled out to various entities to provide them information regarding their patients and their care. Visits to emergency rooms, compliance with needed care. In terms of provider support, we have these definitions. It's basically all tools that will, we hope, improve care if we can roll out data that's useful. One of the biggest problems in practice that I have was dealing with the data that I'd get from Select Health and continuously having to correct it, but there's no other way to get it right. So docs just have to get an interest. Part of my interest in doing that as a practitioner was just an interest in quality, but it doesn't take an awful lot of cash to get docs interested. I have several stories that, it's surprising how much pushback you get for not paying attention to compensation, but then when you actually come up with the contract, they're not really earning that much. I think they just want to have that issue dealt with. In terms of focuses, there would be on preventable diseases, substance abuse, obesity-related disorders, diabetes-related disorders, and detectable and preventable malignancies. In terms of, these are the goals for HPN development this year. We also want to look at overutilization of services. These are the areas that we've been looking at mostly this year. They obviously change depending on technology and what's in vogue. But yeah, I spend most of my time looking at utilization review for high-end imaging, emergency room visits, pain management, readmissions, and lack of appropriate planning for end of life. This seems to be reiteration of the first page. Of interest to Dr. Harston when he developed these slides was areas that were not well addressed by healthcare reform and were things that are going to need to be dealt with eventually. And these are listed. Physician supply, because obviously we're going to need more providers if we have a lot more patients covered. The lack of ability for physicians to practice according to evidence base without a protection against malpractice suits, which is all state-based law. It's difficult to dictate on a national level. Effective, efficient practice just has to do with incentivizing physicians to practice in these group models where they're no longer in total control, which is something that I think they can probably be incentivized to do, but it's difficult to organize. Appropriate use of high-cost services. Again, people look at that as care rationing, but there's, for most of these procedures, there's guidelines being developed, and you just have to get buy-in that we don't always have to use the newest technology to get to where we need to go in an efficient manner. We still run into an awful lot of fraud and abusive coding. Yes?
I've noticed that there's nothing in here about prescriptions. Does that mean that healthcare reform does address prescriptions effectively, or a miss?
Well, specifically, Doug, do you know of the two Dougs? I mean, they're covered. It's just I don't know about proscriptions for prescriptions.
Changes in Medicare do fall under exactly what you're saying there, though a lot of effective efficient practices appropriate use of high-cost services. Drugs would fall under that high-cost services.
Well, like, say, for example, Cymbalta is an expensive prescription, and my wife takes it for neuropathy, but its primary focus on why it's the drug in the first place is that it's for depression, but it's a great neuropathy cure or medicine. And every time that she goes for reviewing that, she has to go through and get the doctor's signature on it again, and then they have to fight it, and it goes back and forth, typically 3 or 4 letters on every year. And it's, kind of like, why is that such a big problem when it's a well-known neuropathy pain? I know another person taking it for his multiple sclerosis.
Yeah, well, like 3 or 4 years ago, it wasn't well known and was basically being used experimentally. And then as more data came through that said that it probably has an indication in these areas, then because of the high cost, most plans require a step therapy approach where less expensive approaches are first required. I think what would help the most is if the government would allow us to negotiate pricing, as does Medicaid. But so far, and that was proposed in the ACA negotiations, but it was not allowed. And you can imagine why. I mean, who here does not have health stock in their retirement portfolio? Everyone's getting rich off the same thing. And so it's a huge political risk. I think I'm done.
We have a couple minutes if anybody has questions.
Dave, how much of this is changing or being given, or what kind of thinking is going into anticipated full implementation of the ACA as a
Well, it's all a big, huge compliance mess because we're trying to create products to fit ACA, but we don't have dictums about what the rules are yet. And the longer it waits, the harder it is to get it all together. So what Coventry's doing is basically operating on several levels, creating all sorts of different products to fit what they think might come through to try to get ready. Supposedly, one of the reasons Aetna wanted to purchase Coventry is we were further along in that than Aetna was. But I don't know, maybe that was just marketing.
But are you guys anticipating an influx in the individual line of business? I mean, that's, the ACA is really mostly targeted towards making the individual insurance more available and affordable.
Yeah, yeah, we are, and we are going to participate in that market. To what degree is dependent on acceptance, and I don't know that anybody knows how to predict that.
Is that the pay for performance program, is that a Coventry thing? That must be it's on the slides. Not necessarily, or not globally in Aetna, right?
I think pay for performance is a term that gets used by everybody in terms of describing the mechanism by which we can align incentives.
That's where I was going to go. What do you use can be used for metrics to say, to award that, essentially?
Just about anything that people agree upon. But typically it's things like diabetes care and immunization rates and care in the hospital, care at discharge, readmissions, frequency.
List of overutilization of services, perhaps, a reduction.
And it's useful. There's an HPN that's gotten started, and they're not contracted to be that way yet, but they will be. But they want all the data first, and so we're sending them all sorts of utilization data. And actually, I send the CEO single cases where I think he could reach out and educate a provider. And it's just always surprising, she did that? Why'd she do that? Because, docs don't know we're all in our little silos and we don't know what each other does. Even if we read each other's records, we don't know necessarily for sure what each other does. But at least this way, data will get presented in the same room with all the names, and eventually the names get unblinded, and docs don't like to be outliers. And they usually regress towards the mean.